Okay. Can you see my slide?
Yes po, Doc.
Hindi pa siya natatakpan kasi I'm also looking at some of you on the screen. Hindi naman natatakpan. Hindi. Okay.
Hindi naman po.
Okay. So, thank you. So for this afternoon, I will give a lecture on growth. Okay. So this is the outline. Okay. We'll have lectures and exercises this afternoon. Okay, so growth is basically, it's an increase in weight or an increase in height or an increase in the number of cells or an increase in the cell itself, okay? And this is something that can be measured quantitatively. Examples are the weight, the height, the head circumference, okay? And we want to orient you with growth monitoring so that we will identify what is normal. We will identify the deviations, which could either be physiologic or normal variant or pathologic, okay? And some disease conditions are initially or diagnosed earlier through growth monitoring and measurements, okay? And that would mean earlier intervention and better outcome, okay? So the growth monitoring is very important in pediatrics, okay? We do this every clinic visit of our patient, must be done, okay? And so we will help you identify because growth it's a vital sign, okay? And we will guide you with identifying what's aberrant growth, what is abnormal growth, okay? And to know what is abnormal, first we have to know what is normal, okay? So there are phases of growth from in utero until adulthood, okay? And there are 4 phases, which I will be sharing in the succeeding slides, okay? First is the phase of fetal growth, okay? It's the fastest phase, okay? And it's affected by several factors, okay? It could be maternal, like maternal infection during pregnancy, like the mother having rubella during pregnancy can affect the growth of the fetus, okay? Placental factors, okay? Fetal as well conditions, okay? And this may all have a role in the overall birth weight of the baby once born, okay? So some of the factors in utero affecting growth will have long-term and long-lasting effects, okay? And this is exemplified by congenital rubella, your torch, toxoplasmosis, congenital syphilis, okay, or your other conditions that will have a long-lasting effect. So after birth, we have now the infantile growth, okay, which is particularly sensitive to nutrition, okay? So the impact of nutrition during this stage could have a long-lasting effect as well, okay? One is if there is stunting during the first 2 years of life and not corrected, then it has a long-term impact, okay? It's hard to correct stunting beyond the age of 2, okay? Aside from nutrition, there are, of course, congenital conditions affecting their growth as well as genetic factors, as I will be discussing later, okay? The genetic height becomes influential also later on, okay? Some grow bigger, taller early on, and then they later on approach their genetic potential. So then next is childhood growth, which is the most steady and predictable phase of growth, okay? At this point in time, there is very minimal rate of growth, okay, for these children, okay? It is in between the infantile and pubertal phases where you have pulsatile growth rate, okay? Here it is steady and much slower rate. Now, the adolescent growth phase is associated with a decrease in growth velocity prior to puberty. And then during puberty, that's where we will encounter the height velocity of initially girls and then boys, okay? And again, the growth during this stage is affected by hormones, okay? The testosterone and estrogen primarily. Now, in adolescent growth, the females will have an earlier acceleration of growth because it occurs during the Tanner stage 3 of the breast development. And then this will be followed after a year or two by the growth acceleration of boys. And it's a little later because for the boys, it occurs during Tanner stage 4 of the pubic hair development. So boys achieve greater height velocities than girls, okay, during puberty, okay, although at a later time. And boys grow approximately 2 years longer than girls, okay, so that overall, the average height of adult men is taller than compared with the adult women because of these two factors, okay? So growth, therefore, is an important indicator of the child's health, the adequacy of nutrition, the impact of illness or illnesses, and the general well-being of the child, okay? So likewise, the growth status of infants and children may also be indicators of health and socioeconomic development of the community they belong to. Like in our country, in children less than 5 years of age, 1 out of 3 children is stunted. And that's quite high a number. And that reflects the socioeconomic status of our country. How about wasting? 1 out of 5 children less than 5 years old has wasting, okay? So it's also an indirect reflection of the socioeconomic status of the place where they are, okay? So there are several factors affecting growth. You are aware of nutrition, genetics, illnesses, that's under environmental, and we'll discuss some of this in the next slides. So parental characteristics, okay, like height, okay, may be transmitted from parents to their offspring. So we see tall parents with tall children, okay? That's a genetic rationale, okay, for that, okay? So, but aside from genetics, okay, others are also certain chromosomal abnormalities also under genetics as a factor. We have metabolic and congenital endocrine disorders that may also affect the growth potential of the child. Another factor is sex, okay? Boys are usually heavier and taller than girls during the first years of life, okay? Until the time of growth spurt, wherein the girls become taller than their classmates. We see this around grade 6, grade 5. If they are in a co-ed school, the girls are taller than the boys. And then in high school, now, once you have the growth of the male sex, that's a growth spurt, and then they become again taller than their female counterpart during high school. Same with race or ethnicity, okay? We know that Caucasian children are generally heavier and taller than their Asian counterparts. And there must be a balance of several hormones for growth to occur, okay? So growth at puberty is dependent on the interaction of growth hormone, insulin-like growth factor 1, and sex steroids, okay? Thyroid hormones also affect the growth of the skeleton and other body tissues. Now, there are modifiable factors that affect growth, okay? These are environmental factors, and their timing and chronicity are important determinants of growth. So when we say environmental, it can be prenatal versus postnatal. So example of prenatal intrauterine infection will be your TORCH, your toxoplasmosis, congenital rubella. Okay, so the mother had rubella during pregnancy, cytomegalovirus infection, herpes simplex. Okay, all of this in utero can affect the growth of the fetus, giving birth to a small for gestational age infant or infant with intrauterine growth retardation. So substance abuse, alcohol exposures, we have the fetal alcohol syndrome causing physical deformities and growth retardation as well. Postnatally, okay? You are familiar with the importance of the first 1,000 days of life, and that starts in utero and during the first 2 years of life. Okay, so the impact of nutrition is very important. But other factors are recurring infections, repeated infections, neurotoxins from other organisms causing infections. So infants with chronic illnesses, okay, they also have growth effects, okay? Parasitic infections causes anemia and poor weight gain, okay, and other factors, socioeconomic and cultural. Cultural when it comes to food preferences or a particular lifestyle, okay, or child rearing may have an effect on the growth. So let's look at the patterns of growth. So the normal human growth is pulsatile, okay? There are periods of rapid growth, okay? And we call that growth spurts, okay? And there are periods of there is no measurable growth detected, okay? Or rather than no measurable growth or very minimal growth rate. So this is the normal growth pattern of every child, okay? There is growth spurt during infancy, followed by a period of quiescence, and then it will again pick up during puberty. So the progression of growth is interpreted within the context of the genetic potential of the child, okay? So when we interpret growth rate, we also look at the family history. Are the parents tall? Are the parents short? Okay, we consider that because the child may be healthy without illnesses with the usual growth rate, but shorter than their counterparts, okay? So for us Filipinos, the average birth weight is 3 kilograms with an average length of 50 centimeters and a head circumference ranging from 32 to 37 centimeters. Okay, so about around 34, 35 centimeters head circumference. So let's look at the growth rate, okay? So the individual growth rate varies greatly. Okay, so growth rate of one child may vary from the cousin or from the sibling. Okay, so children grow most rapidly during the first year of life. Okay, we can see here we have a height gain in centimeters per year. So this is the first year of life. Okay, the height gain is actually about 25 centimeters during the first year of life. Okay, and going to the second year, it's about 10 centimeters increase in height. Okay, so at 1 year old, there are 75 centimeters. At 2 years old, they're about 85 centimeters. Okay, so the height velocity decreases with age, and it will again pick up there during the pubertal stage. And then it goes down. The height velocity rate touches zero at 18 to 20 years of age. Okay, we can see here that the height velocity occurs earlier in female than in males by about 2 years ahead. Okay. Now, the body proportion and body shape also change as the child grows older. Okay. These changes are secondary to skeletal growth. Okay. The head becomes smaller as compared to the rest of the body. Okay, you see here the proportion is so great initially, and then that's it. So this is the Scammons growth curve. Okay, wherein we see here the growth of each structure, the lymphoid, the neural, okay, the genitals, okay, as you can see here. So we know that during the first 2 years of life, there is a rapid growth of the CNS, very critical first 2 years of life, okay? There is a rapid growth for the genitals, of course, during the pubertal period. The lymphoid tissues reaches the adult size at around 6 years, but it continues to hypertrophy and then slowly goes back to the adult size. Okay, so this is the different growth rate of the different structures. Very important is the CNS during the first 2 years, during childhood, the lymphoid, during the adolescent period, the genitals. So skeletal growth continues until the fusion of the epiphysis of the long bones has occurred. And when does the fusion occur? In females, 14 years of age, and in males at 17 years of age. Okay? So that's why males really grow taller after their height velocity spurt growth spurt, and they still continue to increase in their height until around 17 years of age. So the genital tissues grow slowly before puberty, okay? And then, of course, there will be doubling in size during adolescence when they become mature and functional. So the lymphatic tissues are small and well developed at birth, okay? And as I have said earlier in the Scammons growth chart, adult dimension is achieved by 6 years of age, and then peaks after that, and then decreases in size. So the brain and neural tissues, they grow completely during early part of the development, okay? And they still continue to grow dramatically after birth during the first 2 years of life. Myelination of the anterior fontanelle and temporal lobes continue during the first year of life, okay? And it is complete by 2 years of age, okay? And the brain continues to grow until 10 to 12 years of age, okay? With an increase in the size of the head due to the development of air sinuses and the thickening of the scalp and the skull. So dental development includes mineralization and subsequent slides, eruption, and exfoliation. Okay. So this begins in utero as well. Okay. And until the age of 25 for the secondary or permanent teeth. Okay. Until the age of 3 for the primary teeth. Okay. Mineralization occurs first from the crown down to the root. So when do teeth appear? Okay, the first tooth appears between 6 to 8 months of age, usually average 6 months of age, which are your mandibular central incisors. So the lower front teeth generally appear first. Okay, the two lower front teeth. Okay, and eruption of permanent teeth begins at around 6 years of age, and at around this time, some of the teeth exfoliate. Okay, they have their or there will be exfoliation, or it may lag by 4 to 5 months. Okay, the eruption of the permanent teeth may lag after the exfoliation of the teeth. Some of our infants will have no tooth at 6 months, none at 8 months. Okay, so some parents worry, but we wait until around 13 months of age and do work up if there is no tooth yet. Some of my patients, they will have no tooth at 6 months to 8 months, but at 9 to 10 months, everything would appear as if normal already. Okay, so they will have 2 to 3 erupting teeth, one at a time or simultaneously after 8 months. So they catch up. So exfoliation begins at about 6 years of age and continues through 12 years old. Okay. So of course, there are other causes for early exfoliation. It could be pathologic. It could be secondary to trauma or idiopathic. So we will now discuss growth measurements and have some exercises. So when we assess growth, we are required to measure it accurately, and therefore we have to use appropriate tools. Okay. So what do we measure when we assess growth? Okay. Almost you have the weight and the height. But in younger children, we also measure the head, the chest, and the BMI can be computed based on the weight and the height. And in some areas, we also measure the mid-upper arm circumference or the triceps skin fold thickness. Okay. So we use an infant scale. Okay. This is an infant scale. We use it in weighing those less than 2 years of age. Okay. But of course, it's dependent on the maximum weight capacity. Okay. So if the child weighs higher than that, then you can't use the infant scale anymore. So how do we weigh the infant? We remove the clothes, okay, the diaper immediately prior to weighing, okay? And then, of course, if they will be naked, our concern is hypothermia. So we do it fast. We lower down the room temperature and get the weight and then wrap the baby again. Now, we also can do paired weighing of the infant, okay? So how do we do that? We first get the weight of the mother, okay? And then we cover the solar panel for a few seconds until the number 0 appears, okay? So even if the mother is there, the weighing scale with the mother is now paired there at 0, and then the infant is weighed, being carried by the mother. So what is reflected already is the weight of the infant, okay? So the mother removes her shoes, okay, steps on the scale at the middle of the scale. She is weighed first, okay? So this is good if the infant is so fretful, okay? doesn't want to be carried by another one or doesn't want to stand alone. Okay, so we use this one. We undress the infant still as we weigh the infant. Okay. But of course, if the mother is too heavy, for example, more than 100 kilograms, okay, and the baby's weight is relatively low, let us say newborn, okay, then the baby's weight may not register on the scale, okay? So we have to ask a lighter weight person, a person with a lighter weight to be paired and to carry the infant. Or if you do not have that scale, you weigh the mother, you weigh both of them, and then you just subtract. For children more than 2 years of age, ideally they should be weighed alone. They should stand at the middle of the scale. But of course, there are some cases wherein we cannot weigh older than 2, some with those special needs children, or even those who are uncooperative. Okay, may be difficult. So since we want to know if the weight is normal or not, or abnormal or pathologic, first we have to know what is normal, okay? So if the infant is less than 6 months of age, we can approximate the weight by just knowing the age of the infant. Age in months, if less than 6 months, times a fixed value of 600 grams plus the birth weight in grams. Then we get the weight of the infant. What is the expected weight? Now, for 6 months to 12 months, we get the age in months times 500 grams plus the birth weight. So what if there is no mention of the birth weight of the infant? Then we use the 3 kilogram standard birth weight of the Filipinos, okay? So that's equivalent to 3,000 grams. So another mnemonics for rapid computation of expected weight from Nelson's textbook will be, this is an example, okay? At birth is, let us say the infant is 3.4 kilograms. At 3 to 12 months, we just compute age in months plus a fixed value of 9 divided by 2, okay? And this formula will give us the expected weight in kilograms, okay? And for older children, this is the formula, okay? Now, another one to estimate the weight is the changes in weight at different ages, okay? So for example, at 4 to 5 months, we expect the weight of the infant to be twice the birth weight. So if the ideal weight is 3 kilograms, at around 4 months, we expect the infant to be 6 kilograms. Okay, 3 kilograms, so we expect them at 10 years old to be 30 kilograms. That's it, okay? So at 1 year, generally, we expect the birth weight to be 3 times. At 1 year, we expect the weight to be 3 times the birth weight. So it's 3 kilos times 3, around 9 kilos. Okay. Another way to approximate the expected weight based on age. So generally, newborn to 3 months of age gain daily weight of 30 grams, okay? So if we see a 2-week-old and then we see them after a week or 2, then we can estimate the weight based on this daily weight gain. For 4 to 6 months, we expect them to gain 20 grams per day, and for older infants, about 10 grams per day. Now, the 30 grams per day approximates is equivalent to around 900 grams per month, okay, during the first 3 months of life. And this is 600 grams per month weight gain during this time, and this is around 300 grams per month increase in weight. And then children gain 2 kilograms per year between 2 years and puberty. So that's something that's constant, okay? 2 kilograms per year. So that's about half a kilo every 3 months, okay? So if a prepubertal child has a weight velocity that is less than 1 kilogram per year, and these children should be monitored closely for possible progressive nutritional deficits. Okay, so they are going down the curve to your wasting, okay, or stunting. But if it's weight, we're talking of initially wasting, okay? So this is an example of the World Health Organization growth chart for boys 0 to 2 years of age, okay? So I want you to be familiar with several graphs, tables that look like this, so that this is one way to track the growth of the infants and children as well as adolescents, okay? So this is what? This is the weight for age chart. Why is it a weight for age? The vertical line here represents the first one that is measured, which is the weight. And the one on the horizontal line is the age of the infant. That's why it's weight for age chart, okay? And we have here it's color coded. Below -2 Z-score, you have an underweight infant, and a below -3 Z-score, severely underweight. Above +2 is at risk of overweight, okay? So let's have some exercises. So a baby girl was delivered via NSD with a birth weight of 3,550 grams. Okay. What is the expected weight of the baby on follow-up after 1 month of age? Okay. Can I call someone? What is the expected weight at 1 month? Anyone? Can I call anyone? Random lang ako.
4,150 grams po.
Okay. Again, ilan?
4,150 grams.
Okay. Yes, you are correct. Okay, thank you. So 1 month of age times 600 plus the given birth weight. Okay. And therefore the infant at 1 month on follow-up will be expected to weigh 4,150 grams. Okay. Next is, how about this one? A baby boy was delivered via CS. Okay. Routine newborn care was done. NBS was done. Okay. We're now talking of 3rd month. Came back for follow-up. Okay. What is expected weight of the baby? So the birth weight is not given. So we assume it to be 3,000 grams. Okay.
$4,800 per
Yes. Okay. 4,800 grams. Age in months times 3 months. I mean, 3 months times 600 plus average birth weight. Now, this infant at 3 months of age on follow-up should weigh 4.8 kilograms. Now, we measure the length or the height, okay? This is a reliable criterion of growth, and this is not affected by excess fat or fluid, okay? It reflects growth failure, if there is stunting, and chronic undernutrition. It's chronic because for acute undernutrition, the first thing to happen is absence of weight gain and then weight loss. And then if the undernutrition becomes chronic, it later on affects the skeleton and the height. Okay. So for less than 3 years of age, we use the recumbent length, okay? And this is to address the normal lordosis in this age group. Meaning to say, if they are standing and you get their height, they are lordotic. So would you expect the standing height to be taller or shorter? Anyone? If less than 3 years old, have physiologic lordosis. If you get their standing height instead of their recumbent length, will their standing height be taller or shorter than their recumbent length?
Shorter po.
Yeah. Yes, it's shorter because of the lordosis. Okay. That is why we want to measure them in a recumbent position. Now, if you get their height standing and it is shorter, then we just add a certain centimeter to account for the lordosis. Kasi ibang bata naman ayaw humiga. Even if they're less than 3, it's hard to restrain them and get measurements like this, the one shown on the screen, on the PowerPoint, okay? So we call this an infantometer, okay? So at least there are 2 persons getting the measurement. One is holding the head against the headboard and straightening it. The infant is looking up on the ceiling. And look at this here. We straighten the knees, and it's the heel that touches the board, not the tip of the toes. Kasi mag-move forward pa yan. So we measure the length based on the heel and the head here on the other end of the infantometer. So for children 3 years old and above, we ask them to stand up, okay? And this is how we get the height measurement, okay? They stand erect with their back against the stadiometer. We call this a stadiometer, okay? And look at it, the occiput, the upper back, the buttocks, and the heel touch this stadiometer, okay? And look at the one who takes the measurement. Must be at eye level rather than standing up and looking down, okay? And there, must be at eye level, okay? And the board, there must be flat and horizontal, okay? Horizontal to the floor, okay? That's how we get the height. So the expected height at birth is 50 centimeters. And the expected increase during the first year is 25 centimeters, okay? So if you get the expected length or height, just like in weight, if there is no given height at birth, then we use the 50 centimeter average measurement at birth. So the 25 centimeters increase in 1 year is actually divided into 4. We have the first 3 months, the second, the third, and the fourth 3 months, the last 3 months, okay? And we distribute the 25 centimeters into 9, 8, 5, 3. So this is something that is fixed. So you have there the fastest growth rate in height, okay, in the entire lifespan will be the first 3 months of life, okay, wherein it grows by 9 centimeters. So that's around 20% increase in the height during the first 3 months of life, okay? So let's have this computation. For 2 years and above, we can estimate the height in centimeters based on the age in years times a fixed value of 5 plus a fixed value of 80 to give you the height in centimeters. Please be careful. It's the height in centimeters, not in inches. So we have other mnemonics, okay? You have a twice the birth length at 4 years, okay? while twice the birth weight at 4 months, okay? And we have a 3 times the birth length at 13 years. So a 13-year-old is expected to be about 150 centimeters, okay, about 5 feet, okay? Based on the birth length of 50 centimeters. So this is another mnemonics. If you are given these specific ages, then you can approximate the height based on the birth length. So this is easy. 3 years, 3 feet tall. And this is the World Health Organization growth chart for length for age for boys. So it's sex specific. It's blue, it's for boys. And you have here the age range, birth to 2 years, which you can also see here, birth up to 2 years of age. And this is a length for age because what you see on the vertical here is the length in centimeters. So this is the length for age for 0 to 2 years male with a blue background. So let's have some exercises again. So a 3-month-old was brought in for well baby visit. Okay, was born NST with a good upper score and a given birth weight and birth length. So what's the expected length of Ara at 3 months of age? Yes, thank you. 62. Okay. As was shown to you earlier, this is the expected increase. First 3 months is 9 centimeters. So that's also equivalent to 3 centimeters per month during the first 3 months. Okay. And the same with the others. Okay. So 62 centimeters. How about Daniel? What is the expected length of Daniel?
73 centimeters pa.
Yes, thank you, Juan Miguel. Okay, 73 centimeters. Again, in the scenario, the birth length was not provided. So we will assume it to be 50 centimeters. And how did you achieve the 73 centimeters? This is a 10-month-old, okay? Where did you get the 23 centimeters? Can we go back to my previous slide? 10 months old. So we add 9, 8, and 5, diba? This is what, 70? This is 22. But our patient is only 10 months old. So if there is a 3 centimeters increase during the last 3 months, that means 1 centimeter increase per month from 10 months to 12 months. So we add 1 centimeter to the 22 centimeters during the first 9 months. Okay, and yes, Daniel will now have a height of 73 centimeters. Now for the linear growth, a prepubertal child whose height velocity is less than 5 centimeters per year should be monitored closely, okay? Because they are expected to have an increase in height of about 5 centimeters per year, okay? So you see, if you monitor, you will now have this signs. Some becomes red flags, okay, that we have to intervene. We have to do something with the nutrition. Maybe there is an underlying chronic condition that is not identified, like anemia, parasitism, pulmonary tuberculosis, and these have to be treated. So we'll go first now to your normal variants, okay? Not all that doesn't fall within the expected is abnormal, okay? So we have variations from the normal range, and these are also still considered normal variants, not pathology. So we have the familial short stature and the delayed constitutional growth. Okay, let's compare the two. So first is, let's look at the familial short stature. So the history here is the parent or both parents are small. So you see, when we measure the growth, we get the history first. We get the family history is very important because we know that genetics is a factor of growth, okay? So as discussed earlier on, there are genetic predisposition. So we are talking of a child whose parent or parents are small, okay? And what happens? This is what we usually observe. The birth length is normal, 50 centimeters. Okay, at 2 years old, 85 centimeters normal, puberty there, bone age is normal. Then there is a growth spurt at Tanner stage 4, okay, and yet the final adult height is short, okay. The pubertal growth rate is pulsatile but lower range of normal, okay, and this is familial. Everything is normal except during the pubertal growth rate. It slows down. Hence, they get a shorter height or almost the same height or a little taller than the parents. Now, how about constitutional delay? Okay, look at the history. The parents are of average height. Okay, so you have excluded already familial short stature if both parents are average height, of average height, okay? So look at it, the child has normal birth length, but the parents' puberty was delayed, okay? So they had late menses, they had, delayed puberty of the parent, although average height. And then the birth length is normal, the same as familial short. But you have here a slowing in puberty, bone age is delayed, timing of puberty is delayed, pubertal growth rate is diminished, but they achieve an adult height that's normal. So there was a delay during the early stages prior to adulthood. Now, how can we predict the height? Okay, there are two ways. One is projected height and one is mid-parental height. Meaning to say, if you have a nephew or a niece at this age, 4, 5, parents are short, you can project the height of the child, or you can compute for the mid-parental height and see what is the possible height of this nephew or niece at 18 years of age, okay? Let's look at the projected height, okay? So we extrapolate the growth of the child along the current channel to the 18 to 20-year mark. So to better explain that, let us look here at a child. Let us say the child is 6 years of age. And we plotted the height of the child at 6 years of age to fall at 50th percentile. Okay, so this is the height of the 6 years old, 115 centimeters. How do we project the height? We look at 18 or 19 years of age at the same percentile. This is 50th percentile. What is the height? At 50th percentile, it will be around 175 centimeters. So I can predict that my nephew or niece, when he or she reaches the age of 19, if he or she is now 6 years old and is 125 centimeters, then she will be 175 centimeters. Mataas, di ba? Okay, that's it. That's projected. What if the child falls under this percentile, 15th percentile at 6 years of age? Okay, let us say 110 centimeters. So the projected is at the same percentile, 15th percentile at 18 to 20 years of age, which will turn out to be around 169 centimeters. Now for the predicted height or the mid-parental height, we have a fixed formula. Okay, so for both girls and boys, 10 centimeters on either side of this calculated value represents the 3rd and the 97th percentile. Okay, so whatever value you get here, you add 10 and minus subtract 10. That's like the standard deviation, okay? Plus minus 10 centimeters will give you the third and the 97th percentile. So for the girl, okay, we subtract 13 centimeters from the father's height. And we just add the actual height of the mother, okay? But for the boys, we add 13 centimeters from the mother's height plus the actual height of the father, okay? So, why do we do that? Because that's the general difference in the height of the adult male and female, okay? So that's the average difference in stature between men and women. It's about 13 centimeters, okay? So generally, why 10 centimeters plus minus 10, you would ask. Then it's applied above and below this value to provide a genetic target range, okay? To provide you with a range, because the mid-parental height is one value only, but it could range from less than 10 centimeters plus 10 centimeters. So let us make some computations. So Jules is 3 years of age, a boy with a height of 79 centimeters. And given are the heights of the parents. So can you compute for the mid-parental height?
And 79 centimeters for the
Again, Eileen, what?
179 po.
Okay, let us see. Very good. Okay. So we have a 3-year-old boy. Okay, so mother's height plus 13. Okay, and the mother's height is 155 centimeters. So 155 plus 13 plus the actual height of the father and divided by 2. Okay, so we have 179, but you have the plus minus 10 plus 10 centimeters range for the genetic target height range. So the mid-parental height of Jules is 179, but it could range between 169 to 189 centimeters. Okay. So, matangkad naman si Jules, ano? Next exercise. How about this case? A 5-year-old female with a height of 91 centimeters. Her mother's height is 155 and father's is 173. Anyone? Yeah, if you are done with the computation.
One 157.5.
Yes, you are correct. Okay. We will subtract the height of the father. Tama ba? Yes. Okay. Because we have a female child. Okay. Plus the actual height of the mother. Okay. And again, consider the range. Okay. So, what do you observe here? Yung height ng girl is greatly affected by the height of the father, di ba? Kasi the mother may not be that tall, but if the father is much, much taller, okay? Kasi magma-minus ka ng 13, okay? That's what I observed there, okay? Now we go to the head circumference. So the average head circumference at birth is 35 centimeters, although it may range between 32 to 37. And this should be routinely measured during the first 3 years of life. So sa pediatrics, automatic yon. You get the weight, you get the height or length, then you get the head circumference during the first 3 years of life, okay? So this is the third measure of growth, okay? So at birth, the head circumference is usually about 1 to 2 centimeters larger than the chest circumference. So larger siya sa chest circumference. So at birth, mga 34, 33 centimeters ang chest. And this is how we measure the head circumference. Okay. Using a tape measure, okay, we look at the supraorbital ridge and then around the occipital prominence in the back of the head. Okay. And that's the maximal circumference. Okay. And now this is the increase in head circumference. Okay. And again, another mnemonics to memorize. Okay. The age is divided into 3 months during the first 6 months, and then you have altogether 7 to 12 months. And remember, this is the increase per month, okay? Increase per month. So a 3-month-old will have a total of 6 centimeters increase in head circumference. A 6-month-old will have a total of 6 plus 3 centimeters, okay? 2, 1, it goes by half, okay? And then back to 1 centimeter per year during 4 to 6 years of age. So let's have some exercises. How about this one? A 4-month-old, okay? Oh, the head circumference is not given. So we will use the average head circumference, which is 35 centimeters. And we're talking of a 4-month-old. I'm sorry. Na-press ko yung next. Anyway, we'll go to the next na lang. Okay. So, birth circumference is 35 centimeters. And we have a 7 centimeter increase during the first 4 months. Let's review it again. Okay. So, 3 months, 2, 4, 6 centimeters. And our patient is a 4-month-old, and this is 1 centimeter per month. So 7 centimeters increase plus the birth head circumference of 35, it gives us 42 centimeters head circumference. Now the chest circumference, it's not routinely taken. And I'm good to hear that because I don't routinely measure it actually. Just the head circumference. Okay, but it's good to know, and it's important to know that during the first 5 months, the head circumference is larger or almost equal to the chest. That's by 6 months, they're equal. And then beyond 2 years, the chest circumference is larger than the head. Okay. So what you will notice in older children who are wasted, who have wasting, lumalabas, mas malaki ang ulo nila, which is not normal because they are wasted. They are underweight. Okay, so pati chest nila mas maliit. So parang bakit malaki yung ulo? But actually, it's a normal head circumference, but the child was wasting. Okay? So how do you make the measurement? The measurement is obtained at the level of the nipple line, taken during the phase between inspiration and expiration. Okay, so if the infant is crying, you do the timing in between inspiration and expiration, okay, or in a quiet infant. So at the level of the nipple line, that's where we make the measurement. So we measure the BMI for those more than 2 years of age. It is a predictor of adiposity, okay? But, meron din siyang weaknesses, okay? Because it's just the weight and the height. And we know that when we talk of weight, is that fats? Maybe in infants, yes. But in older children, in adolescents who are in sports, the weight could be because of the muscles, not the fat, not the adiposity. So, not a true measure of adiposity. So we get the BMI based on the weight in kilograms divided by the height in meters square. We can use the table, okay, by getting the height in centimeters and getting the weight of the infant, okay? So we plot it. This is the weight and that's the height, okay, 15 kilograms. So you see, as the weight increases, the BMI increases because in the formula, the weight is in the numerator. So the weight is directly proportional to the BMI. Okay, it's hard to say about the height actually, of course, it's inversely, but it's also converted into meters square. And as the height increases, diba, with the increasing weight, and then share, diba? So it will also, but if the child is 90 centimeters, the same weight, 11.5, or 91 centimeters, 11.6, okay? Bababa ng konti ang BMI niya, okay? Now we have a growth chart also for the BMI for age, okay? And what is this? I think this is the wrong growth chart because it should not be weight here. Because if it's BMI for age, what we should see here is the BMI against the age, and this is height. This is weight for height. So this is a wrong growth chart. So let me correct. This is weight for height growth chart for females. Okay, because it's pink. Remember, if it's weight for height, there is no age that is being assessed. It's just the weight against the height. Okay, so this is not a BMI for age growth chart. So let's have some exercises. 7 years old, weighing 23 kilograms and 123 centimeters tall. So what is the BMI of LW? Can you compute?
15.23.
Yes, Steven, that's correct. 15.2. So you compute the weight in kilograms, and the height of 123 centimeters is equivalent to 1.23 meters square. Okay, don't forget the proper unit of measurement. It's always included because we have to be clear that it's kilogram, not grams. We have to be clear that it's centimeters, not inches. It's meters, not centimeters. Okay. So you always have to be mindful of the units if we talked of growth measurements. Now, mid-upper arm circumference, or your MUWAC, is a measurement of thinness. Okay. And we usually do this in settings where there is no weight scale and a height scale. Okay. And the only thing there is a tape measure. Okay. So we remove the cloth of the child. Okay. We get the average we get the mid upper arm by locating the tip of the shoulder and the tip of the elbow and getting the midpoint of that length. And that's where we put the tape measure. And the tape measure is used to measure the circumference of the upper arm at that midpoint. And we read it at the nearest 0.1 centimeter. It shouldn't be as tight as this one. It shouldn't be as loose as this one when you get the measurement. Just enough to hug the mid-upper arm of the infant. Ito nga medyo mataas sa, this is actually not mid-upper arm, diba? It's close to the armpit. Okay? It should be a little lower. So you get the average. You get the half of the length, and that's it. So we have this one available. Okay, it's color-coded. Okay, this is from UNICEF to facilitate its use and interpretation in the community. So it's suitable for measuring child's MUWAC with range of up to 26.5 centimeters. It's graduated with 1 millimeter precision. Okay. So it's the front side that is color coded. Okay. Red means there is malnutrition. Okay. 11.5 centimeters or 115 millimeters. Okay. And therefore we interpret up to the 0.1. Okay. 11.5 centimeters, severe acute malnutrition na yan. So normal is 12.5 or higher. So the opposite side is the instruction on what to do, okay? And in the steps in taking the measurements. So if the measurement gives you a green color that's more than 12.5, then that's interpreted as normal nutritional status. Yellow is moderate acute malnutrition, and severe acute malnutrition for the red one. Severe acute malnutrition. So you can diagnose some severe acute malnutrition by just this one growth measurement parameter, your MUWAC. Okay? By just knowing the MUWAC, well, of course, excluding other possible causes. Okay? That's it, okay? But generally in a child with this measurement, you can intervene right away. Then we have the triceps skin fold thickness, okay? It provides us an index of nutritional status and can be correlated with the body fat content, okay? We use the tape, the site halfway below the tip of the olecranon and the acromial process on the posterior aspect of the arm. So this is the child, his back facing us, okay? You are the one who takes the measurement, and it's the back part of the arm, okay? So the arm is in a relaxed position. The triceps skin fold is lifted by about 1 centimeter using your thumb and the index finger. That's what you use to pinch the skin, okay? And the caliper is used to grasp the raised skin fold. Average of 2 readings to the nearest with a gauge of at the eye level is recommended. So try to take those measurements at eye level twice and get the average. So growth chart is the most powerful tool in growth assessment, okay? They're intended to be used as a sole diagnostic instrument, okay? They are being used as a sole diagnostic instrument, but actually these tools must be used to also intervene and manage. So it contributes to forming an overall clinical impression as well as what to do next. So we do not stop with weighing, measuring, plotting. We interpret, we do not stop with interpretation. We go to the management. That's how it becomes effective. So the growth charts consist of series of curves, okay, that illustrate the distribution of selected body measurements in children. So we use this. We pediatricians use this, okay, and we get the percentile of the growth of the child, the weight, the height, the head circumference, okay. The evaluation of the child growth trajectories and the interventions designed to improve child health are highly dependent on the growth chart. The US CDC and the World Health Organization released new growth charts to replace a 1997 reference just one. So what you should use is the one that was released in May 2000 for the CDC and 2006 for the World Health Organization. So for less than 5 years old, we generally use the World Health Organization growth charts. And for 5 years to 19 years old, we now use the US CDC. Okay. So what are the basis for these lines? The one that tells us that, I'm sorry, it's turned on the side. So what's the basis for these green lines that they say, oh, this is the 50th percentile for age increase in BMI. This is the 50th percentile increase in height. Okay, so the basis of this are what? Are cross-sectional studies or cohort studies of children, okay, of cohorts of newborns were chosen from different countries, Brazil, Ghana, India, Norway, United States, using specific inclusion-exclusion criteria. So all infants were breastfed for at least 12 months and who were predominantly breastfed for the first 4 months of life. That's the basis for this growth chart. And this is how they grew, and they plotted it and used as norm. So you see the norm is that of an exclusively breastfed infant for 4 months and maybe mixed fed starting 4 months, but is given breast milk until 12 months of age. So I have presented earlier the different growth charts. The first one is the one you see on the vertical line. And the second one for age, for length, is the one you see on the horizontal line. And we have the BMI. This is actually BMI for age. Okay? We compute the BMI and then we plot it against the age. So it should be BMI for age growth chart. And then we have the head circumference for age. So what is lacking here is for sex-specific infant, okay? We have a weight for age for female. We have a weight for age chart for male and down the line, okay? So again, this is one example of the weight for age. Weight for age. And we have here the z-scores ranging from +3 or 3 down to -3. Okay. And what you see here is the age. Age up to 1 year is age in months. 1 month, 2, 3 until 1 year of age. And then until 2 years of age, you also have the monthly age. 1 year and 1 month, 1 year and 2 months, 1 year and 3 months, and down until 2 years. So what I want to point out here is you appreciate the vertical lines. Okay, you appreciate the vertical lines corresponding to completed age in years and months completed. Okay, what I want to point out here is we do not plot between two vertical lines. So if the child is 1 year, 1 month, and 2 weeks of age, we plot it on the completed age in years and months. So we will plot the child at 1 year, 1 month. Okay, so the dot should always fall on a horizontal, I mean on a vertical line. And this is the interpretation of the z-scores. Whatever chart you use, here are the different charts. You see it's BMI for age. And then this is the z-score. And that's the interpretation. I hold you responsible for that. So my question to you now is, how do you interpret weight for length z-score of -2? How do you interpret a weight for length z-score of -2?
Wasted food.
Okay, the answer is wrong. Wasted is below -2. I said the Z-score is -2. So it's not below -2. So no wasting. Am I clear?
Underweight po.
Dito kasi siya weight for length. Hindi rin siya. No, I said weight for length. I didn't say weight for age. So itong interpretation niyo, 'di ba? I said weight for length, Z-score of -2. So no wasting kasi gray zone siya. No wasting. If it's a weight for age, Z-score of -2, still hindi siya underweight. Kasi ang underweight is below -2. So kasama pa siya rito sa below -1. Diba? That's the range until -2. Am I clear?
Yes
Ano?
po.
Another one. Let us look at the BMI for age. What if the BMI for age is a Z-score -3?
Wasted po.
Wasted po.
Very good. Yes, wasted. Okay, so I'm clear with that. Okay, very important itong term na below and above. Okay, so pag +2, weight for length, +2, ano siya? Weight for length, Z-score of +2. How do you interpret it?
Possible risk of overweight.
Very good. Yes, +2. Possible risk. Kasi ang overweight is above +2. Okay? So I hope I made myself clear there in the interpretation. So we go to special growth charts. These have been developed for US children with various conditions, including very low birth weight or small for gestational age, especially for premature, or those with congenital conditions wherein they have their different growth rate and pattern. Okay. So just to show you that we do not apply the usual CDC and WHO charts for those with congenital anomalies or special conditions. But there are many issues in using these special growth charts. It was developed using a very small sample size of patients. And the nutritional status was not assessed as well. Okay. So the AAP still recommends the use of WHO and CDC growth charts instead of special growth charts, okay? With the expectation that each child has the potential to grow. But of course, we interpret it based on also on the condition of the child. So it is expected that there is a range. That's why you have a standard deviation, okay? That one child may grow slower or faster than a cousin, a sibling, a counterpart, okay? And yet we just have to track them if they are not going below the percentile lines, okay? That's our red flags will be if it goes below the, I'll show that later. So premature infants will have corrections for gestational age. So special growth charts, as I have shown earlier, are being used for preterm infants, and the corrected age should be used because if not, the infant may appear to be growing suboptimally. So they may continue to show catch-up growth through early school age, and most achieve weight catch-up during the second year of age, okay? So there is a catch-up, we observe that. So we are done with how to monitor growth, and therefore some changes in the growth pattern in what we see in the growth charts, because each child should have several measurements. We just don't measure it at one point in time. It's hard to interpret with just one measurement. What was the previous measurement? Was it the same? Was it higher? Was it lower? Diba? If it was lower before, then the child is growing. If it's the same, it becomes a flat line. That's a red flag. If it was higher below, it went down below 2 lines, again, that's a red flag. So growth rate could be a first sign of a pathologic condition. And this is what we observe. Poor weight gain will lead to wasting, diba? And then you have short stature, tall stature, you have microcephaly and macrocephaly. Okay, this is our interpretation of the head circumference. Okay. So I will just be flashing the common causes of decreased growth and short stature found naman in Nelson's. Okay, I will just pass by this. Sorry for this one. This is from Harriet Lane. So we also look at the blood pressure, systolic and diastolic. You see it is age specific, and that's the range of the BP of the infant. But okay. And then we have the values for the heart rates is part of the vital signs, okay? But not actually part of the growth, okay? Just the measurements, okay? And that will be all. These are the references. So, let's stop share. Okay, any clarifications? So you're going to have your shifting on Wednesday, I believe, at 7 a.m. So expect measurements. Okay, so yeah, medyo memorization yung ibang mnemonics. Okay, so you might ask, what if you use the mnemonics of 3 times increase in weight from birth weight for a 1-year-old, and if you use the formula for 7 to 12 months, age in months, if you compute and they are a little different, so just make sure that the choices that we give will just be one of the two, okay? And or both will be correct, whichever, okay? Okay. So if there are no questions or clarifications, we can have now the break, but I think we have to stay on a few more minutes before we log out, okay? So thank you, everyone.
Thank you po, Doc.
Thank you po.